Hi, everyone, and welcome. I'm Shelley Gunther, Clinical Marketing Manager at Clarius. Thanks for joining us today for this live webinar, Ultrasound-Guided Fat Grafting, Safe Techniques for BBL and Breast Augmentation. We're excited to welcome back double board certified plastic surgeon, Dr. Mark Salzman, who will share his experience and ultrasound best practices to improve safety and precision in fat grafting procedures. You're among 1,200 clinicians who registered for today's popular event. So again, welcome. Now, even for some of the most experienced plastic surgeons have accidentally performed intramuscular injections while performing blind gluteal fat grafting, resulting in catastrophic pulmonary emboli. And today, Dr. Salzman will show how to perform ultrasound to clearly identify the ever important gluteal fascia and in real time ensure fat is placed above the muscle and into the subcutaneous layer with millimeter accuracy for the best BBL surgeries. Dr. Salzman also uses ultrasound for breast fat grafting to ensure precision and the best cosmetic outcomes for patients having implant surgery. A quick housekeeping note, please use the Q&A box at any time during today's webinar, as there will be a live Q&A session following the presentation and live scanning where sonographer Janae Smith will demonstrate fantastic AI feature for those of you who are just learning ultrasound and a few other little tips and tricks about the Clarius app. I have the pleasure of hosting today's webinar, and just before I introduce our guest, I'd like to share a couple of articles that I hope will set the stage for this webinar. And the first is a paper that we shared a couple of years ago, and there were some very strong recommendations that came about as a result of fatal complications of BBLs, namely fat injection into the gluteal muscle layer causing pulmonary embolus. And the most compelling recommendations included the use of ultrasound prior to and during fat injection, which we'll see today. Now, fast forward to March of 2024 to this retrospective study from the Aesthetic Surgery Journal, which included information from 1,815 patients who underwent ultrasound-guided gluteal fat grafting. And though there were a few complications like seromas or surgical site infections, there were no macroscopic fat emboli complications or mortalities. So the authors concluded that direct visualization of anatomical plane injection using ultrasound guidance is associated with a low rate of complications. So what more evidence do we need? Now, finally, the purpose of this study from plastic and reconstructive surgery was to evaluate the current evidence on patient selection, surgical techniques, and assessment of outcomes with composite breast augmentation, which Dr. Salzman will be discussing today. There's no mention of ultrasound guidance, but Dr. Salzman will be demonstrating his fat grafting technique in a unique case where ultrasound enhances the safety and accuracy of the fat injection, saving the patient a return visit. So perhaps ultrasound will be something we'll be seeing more of in literature in the future. Now, I'd just like to poll our audience before we begin, just to get to know you and your use or non-use of ultrasound in your plastic surgery practice. Now, how often are you using point of care ultrasound in your practice? Are you using it all, rarely? Is it a daily thing for you? I'll just give this a couple of more seconds here. All right, 3, 2, 1, close out the poll. Wow, it looks like a lot of people are using ultrasound, which is great, but there's still several of you that are learning today or rarely. So I think we'll have some compelling evidence here of why you might want to start using ultrasound a little bit more often. So at this time, I'd like to introduce our guest, Dr. Mark Salzman. He has a very impressive bio, only part of which I'll touch on today. Now, originally from Miami, Dr. Salzman completed his undergraduate ultrasound at the University of Florida, and he earned his medical degree from Tulane University in New Orleans, graduating at the top of his class. His plastic surgery fellowship was completed at Duke University Medical School in '92. He's a board certified plastic surgery surgeon since 1994, a fellow of the American College of Surgeons, and an assistant clinical professor of plastic surgery at the University of Louisville. Dr. Salzman has been practicing in Louisville, Kentucky since 1992, and now also practices in lovely Sarasota, Florida. And when he's not operating or teaching, Dr. Salzman enjoys golf, squash, and travel. And I don't think we've mentioned his ultrasound skills, but you'll see for yourselves shortly. So Dr. Salzman, I will hand the presentation over to you.
Thanks, Shelley. That was a great synopsis. So we'll start with this slide. because it kind of sums up the whole thing about my thoughts about ultrasound. And it's kind of like what we learned in medical school by listening to the heart and having a stethoscope. This is the stethoscope for plastic surgeons. It allows us to see beneath the skin, and we kind of know what we're looking at if we take the skin away, because we operate on it all the time as a plastic surgeon. For those 25% that Shelley just showed that really don't do ultrasound, let's just go through a little primer of how ultrasound works. You have a machine that produces a piezoelectric crystal sound wave. So it's an excitation, and these sound waves then bounce off the structures that are beneath the skin and produce what's called an echo. And the machine, the ultrasound device, acts as both a transducer and a receiver. As a receiver, it interprets these waves and converts the amount of the wave, the echo that comes back, and converts it to a shade of gray. And that's what makes a B mode ultrasound image that we're looking at on the right. And on the right, this is what you'd see for a tap block, where the muscle is kind of a dark color, and these fascial separations between the internal, external, and between the transversalis and the internal, which tap plane, they're a little bit more white. So things that bounce off are white, and things that it goes through are black. And that's what we call echogenicity. So higher echogenicity things like bone, fascia, metal, they're going to produce a white color. And things that allow the passage of the ultrasound sound through it and don't really reflect back have lower echogenicity: air, water, and fat. And so if you look at some of these images I've included on the right of the slide, you can see there's a needle that's kind of white. You see the fascia and this left-hand top image where the muscle shows the striations. You see the striations here, and then you see the white. And we're going to see this more clearly in the bigger image, this superficial gluteal fascia, and this is going to delineate the space that we're going to put the fat. In this bottom image, same thing. Cannula is white, deep gluteal fascia is white, the fat between it is black. What about frequencies that we're using for ultrasound? Well, the range of human hearing is 16 to 20 kilohertz, and anything more than 20 kilohertz we talk about as being ultrasound because we can't hear it. Diagnostic ultrasound is somewhere between 1 and 15 megahertz. When we're talking about us as plastic surgeons, we're using slightly higher frequencies than what most people in the past have used, like OBGYN. If you're looking at a baby's head and a pelvis, it may be 10, 12 centimeters deep. You need a lower frequency, 2.5 or so, to see that. Vascular, a little more superficial. Thyroid, 7.5. Where our sweet spot for plastic surgery is somewhere in the 7 to 12. So we're talking about more superficial things. It's a little bit higher frequency. Why use a high resolution ultrasound for fat grafting? Well, like we're showing in the picture, it takes away the blind nature of the procedure. You can see underneath the skin, you can see where the fat is going, so it makes it much safer. So what device do you need for a BBL? Well, the anatomy that we're looking at, somewhere between 2 and 4 centimeters, is fairly superficial. So we're trying to place fat between 4 and 2 centimeters, around 3 centimeters. What kind of device, what kind of megahertz are we looking at? Well, ultrasound frequency relates to depth, and kind of they go in opposite directions. So as the frequency increases, the depth of penetration is less. So we see higher frequencies that are used for higher resolution, but at more superficial depths, where the lower depths of penetration have lower resolution. So we're trying to match the frequency to the depth. So we're looking at BBL somewhere 2.5 to 4 centimeters from the surface. The high resolution ultrasound devices have ranges from anywhere from 2 to 20 megahertz. So the sweet spot is kind of in the middle of the depth range of 7 to 10. And I'm showing this in the slide on the right, that the arrow is between the deep and superficial fascias, and we'll talk about that in a second. So when you look at the devices that most of us as plastic surgeons would consider, you have the Clarius 2 devices, the L7 and the L15 HD3, and I have the cost listed here. The L7 is the one I use, goes 4 to 13, can go up to 11 centimeters deep. You hardly ever really need that, even in the thickest of breast parenchymas. When you're looking at an implant, it may be 6 or 7 deep, but 11's really, really deep. The L15, the sweet spot's a little bit higher frequencies, so the depth goes a little bit lower. So either one of those two devices are pretty good for what we're talking about. If you're going to do more head and neck things and do more superficial things like looking at fillers, you might want to consider an L15. If you're doing more things like fat and breast and looking at breast implants, you probably want to consider the L7. So why use the Clarius for a BBL of the ones that are available? Well, for one thing, it's wireless, and that you'll see when we show you the setup. Having a wireless device obviates the need for putting a big condom on that's dragging over the field. It's in a little baggie. It's so easy to sterilize. If you live in Florida like I do now, you have to document your BBL with video. There's a preset that Claria has for BBL that you just push the button and it gives you this AI. We'll show that in a little bit, but you can also easily video the entire procedure, and you're supposed to keep a version of this somewhere near the chart, so there's documentation of what you've done. And the Clarius makes it really easy to do that. So what about safety? Well, this is a slide I got from Pat Pasmino, who lives down in Florida, and you look at the number of deaths in the y-axis and years along the x-axis on the bottom, and you can see they're kind of going along from 2010 to 2016 with only one death from BBL. And then all of a sudden, when the ASERF thing that Shelley showed in 2017, there were 5 deaths. You're saying, what's happening? You know, how are we not putting the fat in the superficial compartment? How is it getting intramuscularly? And we came out with guidelines from ASERF late 2017, early 2018, and you can see the amount of deaths went down to 2 because people knew you're supposed to inject superficially. And that there was a mandate then from Florida that you'd lose your license if you didn't inject in the superficial plane, and you would put it intramuscularly. And so again, 2 deaths. Then COVID hit and no one was really being operated on in late 2019, early 2020. And then lo and behold, 2021, 10 deaths. And the state of Florida is looking like, what is going on there? And they did autopsies on all of the patients and found out they were all PEs. So there was an emergency rule in 2022 in Florida saying you have to put fat in the subcutaneous plane, and that got extended to House Bill 1471 in late 2023, saying not only do you have to do it, you have to prove that you did it, you have to use ultrasound, and you have to video it. And lo and behold, in 2024, there's only been 1 death. So it clearly is a proven entity that ultrasound will help fat grafting. And here's how I set the thing up. They do make some almost like a baggie that you can buy from different companies. And the reason I do it this way is it makes it a little cooler, not cool like, hey, it's cool, but cooler in that it doesn't overheat as much. So if you take your 1010 drape, 1020 drape, the 3M 1020, it's called an eye drape, and you turn it over so the sticky side is down, and then you put a Tegaderm over that side and flip the thing over and peel off. You can see in the upper right, I've peeled off the little sticky thing, put some ultrasound jelly there. And now I fold this up, and the sticky part is going to stick to the ultrasound device and kind of hold the ultrasound jelly confined to just over the transducer. And now this is all sterile. And then you fold it up, and we use the end of a lap sponge just to tie it loosely. So there is some little bit more breathability to it than when you enclose it in a baggie, and it keeps the jelly, the ultrasound jelly, really close to the transducer. And so that isn't an issue. I found in the baggie, after a while, the jelly would disperse and you wouldn't have good coverage over the transducer. And this obviates the need for going back and reopening it and putting more gel in. You can still see the light, you can still see the buttons and push the buttons. So now we're ready to use this thing. So here's the setup that I do when we do a BBL. I have a little cart with the iPad sitting on a cart. It's usually across from me. I'm left-handed, so I have the cannula in my dominant hand, the ultrasound device in the non-dominant hand, sterile ultrasound jelly on the buttock. And you want to do this, what's called an in-plane technique. So the long axis of the transducer is parallel to the long axis of the cannula. And you can use any cannula you want. You can use any injection portal that you want. If you want to go in the middle at the top of the thigh, you can do that. You can do it in the thigh buttock crease. I kind of like this one because it gets to all the areas, and it's far enough away that you don't see fat extruding from the hole that you're putting in. Just a little 11 blade hole because it's a 4mm cannula that we're using. And where we want to put the fat, I'm going to start with this more anatomic look at this. And there's actually 2 gluteal fascias. This is a cadaveric cross section where the yellow is the superficial fascia, or kind of like scarpus fascia. And this is the deep, white, thick fascia that's over the gluteal muscle. So the superficial compartment is more septated. You can see these little septations. So fat isn't going to flow as freely as it will in between the deep and the superficial gluteal fascias. And this is just showing that we want to inject in this green space between the superficial and the deep gluteal fascias, which are both going to be more white because fat will flow in here. Here, you're going to get more of a peau d'orange. You're going to pull on those vertical septa, and you're going to see that the fat, it's difficult to make it flow. So that's where the fat goes into the green. So the first thing you do is find the cannula, and the cannula is going to be this big white thing that's moving. Remember, things that are metal are going to reflect more in echogenicity. So you have the superficial gluteal fascia. You can see the striations down here where I have deep gluteal fascia, and here's the deep gluteal fascia, this white line. So this is the sausage we're trying to create between this line and that line, using the white cannula, and it's the thing that's moving. If you're a neophyte at this and you're looking at this gray image, I don't really see anything. But once it's colorized like this, makes it really, really simple. So what's over here and kind of gray is the dermis, and that they've painted that a little bit purple. And then the very superficial gluteal fascia above the superficial gluteal fascia is the superficial gluteal space, and that's more of an orangish brown fat. Not histologically, but just in this picture. And then we're trying to stay between the deep gluteal fascia and the superficial gluteal fascia. Here's our cannula. And this is what you see with a fat injection. So we've localized the cannula because it's wiggling. And this is the gluteus muscle, deep gluteal fascia, superficial gluteal fascia. The white thing that's moving is our cannula. And here you can see the fat streaming out. And you can see this space. You can see the fascia down here going downward. I'll play that again. See, everything's just being pushed in this bolus of fat. And when you look at this with a artist's rendition, you can see here is the space that we're going between the superficial and the deep gluteal fascia, and you're seeing this cannula between the two, and now you have this big bolus. So you don't have to move the cannula. You just inject, and whether you're using a static injection or you're using a reciprocating powered injection, you're just leaving it in one spot, and it's going to make its space. It's not going to invade the deep gluteal fascia. It's not going to get intramuscular, and it's not going to invade the superficial space. And here you can see all these septations that I'm talking about in the superficial space that would give you more of like a peau d'orange if you were trying to inject in that space. So here's how I do it. I go to the highest point of the buttock where I want it to be, and I inject that first and kind of create the mountaintop, if you will. And then my second injection is usually inferior to that. And then my third one, I'll usually go medial. And then the fourth, I'll try and round it out. And these aren't exactly where, but this is just how I do it in this direction. Everybody has their own way of doing it. So this would kind of be including the hip dip to give you that heart shape of the buttock. And this is what you end up with, are these boluses. Then you come back with a cannula, and going back and forth, you can kind of equalize this fat because it'll distribute just with extrinsic pressure of your hand and moving the cannula back and forth, and you'll get more of a homogeneous deposition of fat. And you can see this on ultrasound. You can go back and see, well, here, there's plenty of fat here, but I'm missing some fat in one spot. So here's my second bolus injection, and you can see it, the fat streaming out, and it's pushing the fascia up and pushing the fascia down. And so all of this more whitish looking is the new fat that we've added. So if you come to a space that you don't see fat, it's going to clinically correlate to an area that's kind of devoid of fat when you're looking at the buttock in real time. And this is a movie we made a couple of weeks ago. I've already done the tumescent, and now I'm doing power-assisted lipo. You can see we're using the Viality device there in the back right. This is Vibrostat Pro. And once that fat has been treated with the surfactant and loaded into, I use 60 cc Toomey syringes and a 4 millimeter cannula, but you can use pretty much anything you want to use. I'm not against the power assisted. It's a little harder with the Viality. It doesn't have a setup to do it with power assisted. At least I haven't figured out how to do it yet. So now I'm finding the thing that's moving. You can see on this video, that big white thing that's wiggling is between, here's gluteal muscle. Here's superficial gluteal fascia, and my big white rod right there is right in the right spot. And once I get that in the right spot, then I'm going to inject. So it's kind of a one-man show. One person does it. It's hard for me to have someone else move the cannula, and you can see the space expanding as I'm putting these fat grafts in. And it's very satisfying to see because you're safe. You're in the right spot. You're not worried that you're going to be in an intramuscular type injection. I'm going to show you later when I inadvertently put the cannula into the intramuscular space and then I see it. I didn't try and do that. I wasn't saying, oh, let me show you how I can do that. I just inadvertently did it. And every time I watch somebody do this on videos, everybody does it. So it's hard to know that you're in the deep gluteal muscle space. And here's another injection. You can see fascia down and superficial fascia. And here's the new fat that we've injected, and it's in the right spot. So it's not hard to do. It's just you got to practice doing it with two hands, because one hand's using the device and one hand is using the cannula. And we do it, one at a time. So my assistant will always have one loaded for 60 cc's, and then we just keep going. This only takes, if I'm not filming it, 5 to 7 minutes to inject the whole buttock. It doesn't take much longer than if you do it with a reciprocating powered cannula. You can see again, I'm above the gluteal fascia, and now I'm going to put another bolus in. And sometimes I have to get started with one hand. My hand's not big enough to go to the back of the cannula. So you see, I'm not really looking right now. I'm just pulling it backwards as I inject because I've already started in the space. There's no way to make it not in the space. And then if some escapes into the superficial space, which it can, I'll mush it around like that to make it smooth. There's a little bit more left on this bit. I want to show you where I put the cannula right into the muscle, but I recognize it because I'm doing it in real time under ultrasound. So the one thing about the viality is I don't think I've figured out how to use that little port at the bottom. It's not as slick as you would like. So we end up just opening it up and sucking it out, which kind of converts it into an open system, which I really don't love. But I like the way the fat retention is better using the surfactant. I think that is important. So I still haven't put it in the muscle yet, but it's coming up.
I think too, Dr. Salzman, the fact that cannula is a really decent size
makes it easy to see.
It's not difficult to see, right? Yeah.
It's 4 millimeter cannula. And I don't, because you're doing under ultrasound, whether it's flexible or not flexible or lower lock or like this is a Toomey type syringe, you can see the fat just streams in, and here's muscle down below. Here's superficial fascia. And you can see the fat is just contained into the exact spot that you want it. And you can just kind of go along and putting, 1, 2, 3, 4, and then you go back to 1. And so you're creating this mountain, if you will, and filling in the hip dips at the end. So you're getting a nice, you really see that fat expand there. And so it's very satisfying to know that you have no chance of creating an intramuscular injection when you're watching the entire time where the fat goes. Here's where I go into the muscle, I'm pretty sure. Oh, look at that, guys. Yeah. Mark Salzman right in the middle of the muscle. How about that? Okay, I was not trying to do that, I promise you, all right? So I look at it and I go, oh, damn, that's in the muscle. Let me pull out and go again. So it can happen to anybody because of the angle of where you are. So now I back off. I don't put the injection there. I go find the cannula in the correct spot, and there it is sitting in the superficial space. So this protected me from doing an inadvertent submuscular injection. You can see how big the space is now because it's filled with fat. And when we started out, it was only maybe 1.5 centimeters, and now these are 1 centimeter gradations. So it's almost 2.5 centimeters of thickness. So we're putting more fat into the space. All right, we'll go to the next one. Here's just some BBL pictures, posterior only. I think this one is anterior and posterior. Yeah, she had a tummy tuck as well, and press something, lift, I think, with an implant. Here's just BBL only to kind of give her a little more shape. BBL from the side. Summary for this is with BBL using a Clarius device, you have a precision placement of fat into the deep gluteal subcutaneous space. You can see it every single time, so you're safe. And if you have to, it's very simple with the Clarius device, just to turn on the iPad video and video the entire thing. And now you have your chart video, and that probably someday in the next 2 to 3, 4 years, will be probably every state will lock on to that from Florida. We're just a little bit of ahead because I think we've killed more people. So what about HRUS guided fat grafting to the breast? Why would you want to do that? Well, for me, when I'm dealing with asymmetry, I would rather put two similar size implants and fix the parenchymal disproportion with fat grafting, so-called hybrid breast augmentation. That way, as the woman's breasts age and she changes in weight, pre-pregnancy, post-pregnancy, weight loss, whatever, we have a much greater chance of long-term symmetry. And I don't criticize anyone who wants to put dissimilar size implants, but in my experience, the dissimilar size implants are only creating size that is good for the week you put them in. At every other weight, the lady's off. So you might want to consider at least offering the patients with gross asymmetry fat grafting to even them out and use the implants that are the same size. There's lots of people who just lack upper pole fullness, whether they've had a lift that's fallen a little bit, an implant that's fallen a little bit, and you want a disproportionate amount of enlargement in the upper pole. Again, a hybrid type of breast augmentation where you're enhancing fat just to the upper pole is certainly worthwhile entertaining as a secondary procedure. If you have a wide sternal space and you're going to use a more moderate to less than high profile stance of your breast implant, sometimes it'll look like a tunnel between the breast because there's such a stark demarcation between the tight skin over the sternum and the takeoff point of the medial aspect of the breast implant as it interdigitates with the surrounding parenchymal structures. You can create that and soften that cleavage with fat grafting. And I'll usually do that as a secondary thing. I won't do it at the same time as a primary aug. I'll come back in 3 or 4 months when everything softens up and do it. One of the more common things in my practice is the patient who has implant fatigue or has gained weight, or I put them in 30 years ago and now they're broken and they don't want new implants put in and they don't want to lift. And then like the picture on the right, everything collapses into the big subcutaneous hole that you've got, and you need to fill that with fat. Or in the patient who wants the implant out and you're not going to do anything to the capsule, you're going to keep the capsule there. So you're simultaneously going to remove the breast implant, retain the capsule, and fill the space between the capsule and the skin with fat, the so-called SEEF procedure. So there's a bunch of reasons that you might want to consider fat grafting the breast, and the ultrasound device is helpful in all of them. So this is what you're looking at in a B-mode ultrasound of a patient with breast implants. This is a textured, probably center is what it looks like, implant. The white line here I'm pointing to capsule is the breast capsule. And then you have breast parenchyma, and this lady has some dense breast parenchyma, and then subcutaneous fat at the top between the skin and the parenchyma. And it's sometimes hard to put the fat as deep as you might like into the parenchyma because it's so dense. So you end up putting it right at the top of where the parenchyma and the deep subcutaneous fat. So you're below kind of the scarpa's fascia. This is your sausage that you're trying to create with fat grafting to the breast. So sometimes I said this already, it's hard to place it. So it's easier to place fat in fat. And it's very easy to see the capsule in a SEEF procedure. So you're going to keep the fat if it's in parenchyma or in subcutaneous tissue, but you're not going to put it through the capsule into that big hole that's there, even if you've closed off the space or treated with electrocautery or treated it with electrocautery and closed off the space. You don't want to put fat in that hole. I've seen it done, and it usually undergoes necrosis because there's no living tissue that's touching it. And the way I do it is I advance the cannula to the beginning of where the tunnel is, and then I pull back and inject in a retrograde fashion so that I know that it's in the spot that I want. And this is a lady who had submuscular implants. We moved them to the subglandular space, but she had these soft tissue depressions from having 2 or 3 operations in the past. So we're going to try and clean all that up with fat grafting and fix the apex of her breast, which she had a very rapid takeoff of the upper pole of her breast that she wanted softened so that you didn't see such a stark contrast between the top of the implant and the bottom of her chest wall. So we're going to try and fill that in with fat. Now this one's a little tricky because there's no capsule. We've moved the implant on top of the capsule, which was on top of the muscle. So the only space is really between scarpas, which you can see, and the breast parenchyma. That's what I'm trying to show. And here's the implant down here. This is the inside of the implant. So my cannula is almost just below the skin, and I want to make sure that I'm putting it in the correct space. So here's the fat kind of streaming in, you'll see in a second, and it's filling that space. And as we head up, it's a little easier because then we get to a place where we can actually see muscle. So here you can see muscle at the bottom and skin here, and this is parenchyma that's more white. And here's my cannula. I'm putting it on top of the muscle, and you'll see the fat go in here in a second. The thing that's wiggling is always the cannula. The white wiggling is the cannula. And here the fat's going in. You can see it kind of streaming in. And all of this is new fat. And you can see it pushing down the muscle, and there's the cannula and the fat going in between scarpa's fascia here and the fascia of the pectoralis. See the fat just kind of streaming in right there. It's a very satisfying thing. I'm going all the way up here to create that space so that there's not such a stark takeoff. You can see how stark that looks right there. We're trying to fill that in. And here you can see how that's so nicely filled with fat. So visually it looks better, and you can see it under ultrasound as well. And here's just some more of putting that fat. The cannula is the white thing that's moving, and we're going to inject in a retrograde fashion. We're going to find the end of that tunnel and then pull back and inject the fat. And here's all the brand new fat right there is more of the white stuff. Here's the muscle and pec fascia. And that's what you get when that's all said and done. And here you can see, perfect, just beautiful fat grafts, muscle, fascia, superficial fascia, and the fat's all in the right spot, and it's got it all filled in nicely. I think there's one more little part of doing this at the apex. See the fat grafts, muscle, fascia, perfect. Fat's right in the little, I call it a sausage. It's right contained in that little sausage of superficial fascia, and there's more fat going in. See it going in and pushing that fascia up. And so you're seeing it both visually on ultrasound, and you're seeing it visually kind of fill in that declivity that you have at the apex of the breast implant. And that's all brand new fat filling that space. So nice to see, so fun to do.
Makes it so precise.
Very precise. And this is also very helpful for some of the adverse sequelas. You know, fat grafting is not without its problems sometimes, and you get fat necrosis and oil cysts. And here's a big old oil cyst that's sitting in a lady that I did fat grafting of the breast. And how do you fix that? Well, if you have an ultrasound device, here's your ultrasound needle, you suck the oil out and you're left with this little tiny thing. So having that ultrasound device really does help both with the pre and any adverse AEs that you get. I'm going to leave this now for you guys to think about. We're going to be having a workshop December 12th. It's the Florida Society of Plastic Surgery meeting, which is, if you've never been to the Breakers, it is just beautiful. I went 2 years ago. And the meeting's not all day, so there's time to go to the beach and time to play golf. And the hotel's all decked out in Christmas regalia. And the day before, on the Thursday evening or Thursday late afternoon, we're going to have a workshop, and Clarice is going to be there for this with hands-on plastic surgery skills for both looking at broken breast implants and normal breast implants, as well as Pat and I will be there for BBL, Pat Pesmino for BBL, hands-on. We have a model that Oni Garcia does. If you've not seen it, it's pretty cool, that can replicate the human buttock. And we can get you guys more confidence in doing this by doing it hands-on.
If you're interested in additional hands-on training, yeah, fill out that poll and let us know, and we'll pass on the information to Dr. Salzman.
Conclusions for me are that high-resolution ultrasound is really helpful for both fat grafting, the buttock, and breast. I think it's the state of the art, and at some point in the near future, it will probably be the standard of care. And you should look into this now, because I think everybody's going to be doing it soon. It just makes it better, being able to see. It takes the blinders off. It certainly makes it safer. You're not going to put it intramuscularly. You're not going to put the fat through the capsule or injure a breast implant. If you're trying to do it with an implant, you're not going to put the cannula into the implant, because you see exactly where it's going, and you're directing the fat to a very finite space that's usually bounded by some fascia, and the fascia is white, and you got this big moving white rod that you're sticking in this very finite space. And if you have to, like we do in Florida, document this, you can do it quite easily with video. And that's my thank you slide. I'm now living in beautiful Sarasota, Florida. This pair of birds is always on our golf course. I think it's a husband and wife, and they make a ton of noise when they get mad at each other, I think. So there's my email. If anybody needs to reach me, please feel free to reach out to me. I tend to get a few emails on this after we do any type of a course. Happy to help. I'll turn this over to Janae.
Great, thank you. Yeah, Janae's going to give us a live demo of scanning for the BBL, and she's going to show us a few of the features like T mode and the procedure recording mode as well. So Janae, I'll hand it over to you.
All right, thanks, Shelley, and thank you, Dr. Salzman. For the demo today, I'm going to be using the L7 ultrasound scanner, and I'm going to start here, and we'll select the BBL preset. And I'm going to start in a sagittal orientation right over the gluteal region. And we can see here with that preset, we get a beautiful image of this anatomy here. We can see the superficial gluteal fascia right here. It's nice and bright white echogenic. And then just a little deeper is the deep gluteal fascia. Go live again here. And if we can adjust some of our imaging parameters given the patient's body habitus. The most deep structure here is we can see the striations of the gluteal muscle. So we can adjust those parameters just by touching the screen. We can also use the voice control feature, and we can activate the voice control feature by either pre-programming the button on the scanner itself, or we can access it with the tools icon here, and we'll turn on the voice control. And from here, we can adjust things hands-free. So we can increase our gain, we can decrease our gain, we can increase our image depth, increase depth, we can decrease the depth, we can freeze the image, we can capture the image. So those are things that are valuable when we're doing a procedure in a sterile field. Yeah. And let's
Let me interject something here. One of the first things you want to do is what she's got is that where you want to go right in here in the middle is in the midfield where you have the most accuracy. So that's a depth thing. So if you're at 4 centimeters seeing the muscle, then you're injecting somewhere around 2. That is in the midfield, and that's the perfect way to make the depth. So if you had it at 6, it would be too much. If you had it at 2 and you couldn't see the deep gluteal fascia, that would be too little. So this is exactly right.
Great, thank you. And let's have a look at the new AI-powered T mode. So this is still being used for educational purposes, but we'll have a look at it here now. So we access that by selecting the modes icon here at the bottom of the screen. And we're gonna look at the very bottom of the list and turn on the T mode. So here we can see a side-by-side textured graphical representation of the different tissue layers. And when we slide up and down into different areas of the tissue, we can see that the thickness, especially of that fat tissue there in the middle, changes as we're scanning live. And when we freeze the image, we can see that the AI automatically applies a text annotation of the different tissue layers there for us. And on the left-hand side of the screen, where we can see the B mode grayscale image, we can adjust the opacity of the overlay onto the tissues just to distinguish between those tissue layers even more pronounced. So this feature is great for beginner sonographers or anybody who has any question about what layer of tissue they're looking at. That's great. And the last feature I'm going to talk about today is the procedure recording mode. So we'll go back to grayscale here. So to access the procedure recording mode, we're going to head over to the settings menu. And we're going to scan down until we find the Clarius live header. And we want to make sure that the camera is enabled and the microphone is enabled, in which they are. So we're going to head back over to the scanner here. And again, we'll access the tools menu, and we're going to turn on the screen recorder. And right off the bat, we can see basically a picture within a picture. So this feature allows us to record the anatomical ultrasound procedure as well as the clinical procedure at the same time. And this is really helpful for documentation purposes, what Dr. Salzman was talking about earlier, where it's mandatory to have that record. And we can access the control center here at the top right hand of the screen and select the screen recording icon. And now we're live, and it records both aspects of our surgical procedure here. I'll freeze the image there. Yeah. And I'll hand it back to you, Shelley.
Great, thanks, Janae. Yeah, really nice demonstration. And yeah, I don't know if you noticed, but the BBL, the T mode for the BBLs is like she said, an educational tool. And I mean, you'd only have to use it a few times before you start recognizing the grayscale anatomy. So it's really helpful for that, almost like a textbook overlay. Great. So we are very excited about that, and looking forward to hearing all about how this makes ultrasound a little less intimidating for some of you with new users. Now, just before we open the floor to questions with our guest speaker, here's a quick poll for you. We'd love to help everyone continue their journey in bringing ultrasound to your plastic surgery practice. So please do complete this poll if you'd like any additional information, and you can click on as many options as apply. And while you complete the poll, I'd like to take a minute to tell you a little bit more about the Clarius L7 HD3. You'll no longer have to purchase a bulky, expensive ultrasound system that's complex to learn if you're ready to add ultrasound to your practice. Miniaturization and innovation means high definition imaging is now easy and affordable, with image quality that rivals traditional systems, but at a fraction of the cost. With high definition imaging of the skin, muscles, and fascia layers, you'll gain confidence in your cannula placement, easily identify the cannula tip, and place fat more accurately. The Clarius is also wireless, freeing up space with zero footprint, and it's fully immersible, so much faster and easier to clean and disinfect. Now, only Clarius scanners deliver wireless scanners with an ecosystem that includes a free app for your iOS or Android device with free updates. And included with membership, the advanced aesthetics package, that includes AI-powered features that you saw today, like T-mode AI. Janae demonstrated that beautifully, and procedure recording mode that allows you to document your entire procedure, and voice controls that free up your hands during the procedures. Great, so let's get to your questions. I wanted to let you know that a recording of today's session, as well as a PDF copy of the presentation, will be emailed to you in the coming days, so keep an eye on your inbox. All right, Dr. Salzman, we have a few questions here. Somebody asked, which model does Dr. Salzman use?
I have the L7 HD3.
All right, great.
And I'll just give a synopsis of why. I think the L15 is probably better if you're like a facial cosmetic guy or someone owning a med spa and you're going to do more filler things, because its sweet spot's a little bit deeper, a little bit more superficial, a little higher frequency. So you may have trouble with a 15 and a big lady seeing the implant that's 6, 7, 8 centimeters down. But you'll see a filler better at 1.2 centimeters down, let's say. You got to pick where you want, the sweet spot to be. But for the vast majority of plastic surgeons that are looking at breast, doing BBL, doing fat graft to the breast, looking at ultrasound for broken implants, personally, I think the L7 is better.
Yeah, and there was another question about advising on the L7 or the L15. So I don't know, like I find the L15 has a little bit bigger of a field of view as well. But as Dr. Salzman said, ultrasound's always a bit of a trade-off. The L7 kind of covers all areas, especially if you're not looking for really detailed anatomy in the near field, that the L15 would be a bit better.
Yeah, if you're looking at more
to use.
fillers, then L15 is going to be a little better. But
Yeah,
where do you, it's like you said, what do you want to give up? Do you want to give up not seeing an implant in a big lady, or do you want to see that filler complication a little easier? Because you can still see it with the L7. It just may not be as clear as the L15. Anyway.
Yeah, and there's a question, do you offer hands-on training only for surgeons or also for providers offering non-surgical BBL?
That can be for anybody. The teaching courses usually go over things that plastic surgeons would want, but if it's a filler type course, there's other practitioners that offer those that'd be more in line for what a med spa might want. I don't think you'd want to waste your time learning about BBL and fat grafting and looking at broken breast implants and doing tap blocks and pec blocks if you're not a plastic surgeon.
There's one question that says, can you use this for fat grafting on a face? And I'm not exactly sure what this is, whether it's the scanner or
yeah, you can. You can put it. I've done that. For a patient with skin on top of muscle and no subcutaneous fat, like a Romberg's type thing, and trying to place the fat directly into the mimetic muscles where it's more likely to survive, you can use this device. If you're trying to place fat or filler and you want to put it in the exactly where you want it in the temple in the correct plane, this is indispensable. If you're trying to put fat grafts and you're trying to fill the SOOF, this is indispensable. So yes, you can use this for fat grafting to the face. We didn't talk about that because I thought it would take too long to go through all three things, but Shelley, we can put that together for another time.
Sure. Yeah, that's a good idea. All right, there's a question. Can we augment the breast just by injecting fat? How long does it last before needing a second injection?
Well, it depends on how you treat the fat and where the fat goes. I think that some of the data that comes out of the Viality is that the fat grafting amount that stays is in the 90-something percentile. And so I've only used that probably for the last year or so. I used to use the redhead device, which didn't have any type of a liquid that you placed inside the redhead. And there is some cell stability that comes with the surfactant that you use in the Viality device. So that's part of it. But I tell every fat grafting patient that you can't overcorrect in hopes that, let's say you put 150% of what you think you need because 50% is going to die and you're left with 100%. You're going to have to do it incrementally. So all fat grafting patients have to accept that there may be another fat grafting in their future in order to get the exact look that you want. But for the most part, for breast, it's rare that I'm going back and doing it more than once. We're usually in the 50 to 200 cc range for fat grafting. And unfortunately, the women that want only fat grafting to the breast in lieu of a breast implant are usually fairly thin and aesthetically built, and they don't have enough subcutaneous fat to donate from the hips or paraumbilical region to make a decent sized breast, and hence the necessity for an implant. So the answer is yes, you may have to go back and do it again, but for the most part, you don't. I'd say 95% of the time, for me, it's one and done.
Someone wants to know how much fat you inject per buttock on average.
Well, I live in Kentucky when I was doing most of these cases, and we don't have the ethnic fat desires of having the bubble butt that I see on the East Coast, West Coast, and in Miami. So we're doing more of a Caucasian patient population. My average is probably 650, 700. I've put as much as 1,200 per side in an ethnic lady, but somewhere around 600 to 700 is probably more the middle of the road for me.
Which method do you usually use to purify the fat in BBL and breast fat transfer?
So I use the Viality most of the time. For very, very small amounts of fat, we'll roll it. And for 50 to 100, I can't remember the name of the little bag that you inject it in, and it goes around and you wash it. I never can remember the name of it, but I use that for 50 to 100. The Viality is kind of an overkill if you're only doing 50 to 100 cc's. So anything more than that, I think Viality makes sense because the washing technique and the adding of the surfactant has been shown in a couple of papers now to improve the fat take into the 90th plus percentile. But it is expensive. It's more than 500, less than 1,000 to buy the thing.
Wow.
So it's a cost you have to consider.
A couple of questions about sonographers or registered ultrasound techs. One person asked if sonographers utilized in this specialty, or do you offer specific training for registered ultrasound technologists? Guess they're getting into the business.
I don't know. Most of the people I've trained, in fact, all of them were MDs. There may have been a PA or nurse practitioner in there, but I've never done the ones for medical spas. There's some other courses that kind of go in that direction, but we have not had those trainings in my office.
All right. Do you measure the quantity of fat? Do you inject comparing long-term if the fat is still there? I'm not really sure I understand that question.
Yeah, initially we did 3D images and looked at the increase in the buttocks, and it's fairly compelling to use the 3D Canfield vector camera, and you can actually see the pre and post, and it'll show you as a percentage of and what your increase is. And I don't think that the take is ever 100%, but with Viality, it's gotten better. I think it used to be, for me, maybe 70% at best with the redhead. And I think with Viality, it's closer to 90%. I don't think it's 95%, but I think it's closer to 90%. And the key is to have as much of the fat you put in not touching other parcels of dead fat. So you can't keep putting it in a big lake, because the fat that is not touching another living fat cell can't survive by plasmatic imbibition for a couple of days until it gets vascularized. So it's a game of how much can you put in and will it live? The more you try and put in, the tighter it is, and you get some ischemia from the fat, the pressure, not allowing the capillary oncotic pressure to allow nutrients to get to the fat. I think that's one issue. So if you're really trying to do it huge, that you're probably better off staging it and doing it in 2 sessions, so you're not wasting fat that would otherwise survive, because there's only a limited amount of donor fat that any patient has.
Do you use a barbed cannula to harvest the fat?
I'm not sure I know what a barbed cannula. I usually use an explosion cannula, it's called. It looks like a Mercedes that's been blown out. It's a basket, and for the bigger ladies, it's a double basket, so it's got 2 baskets next to each other. There's another one called an accelerator, but anything where the holes are bigger, so you don't want the fat to go through a little hole. You're going to avulse the fat at high negative pressures that are going to blow the fat cell up before it ever gets into the Viality device. So you also want to lower your pressures to no more than 12 millimeters of mercury. So you don't want it -20, because that, as the fat is being avulsed off its vascular pedicle, at 20 millimeters of negative pressure, you're blowing the fat cell up. So lower pressures, and I think Vaser helps a lot. It's been shown that Vaser has a 95% fat retention rate, that the fat is viable at 95%, what comes out with Vaser. It used to be thought that the Vaser was busting the fat cell. It's not true. What the Vaser does is just separates the fat from the vascular pedicle, so it allows for very small amounts of negative aspiration pressures for the fat to then travel down a big hole and get into the Viality container, where you can solidify it with the surfactant and keep that cell alive. So I think the bigger cannulas are better with lower pressures.
So what size cannula? Like,
usually 4s. And I don't use a 5. Usually it's a 4 millimeter cannula that we use. And with power, I'm using the Vibrostat Pro liposuction, which is kind of like using the 3M device, but on steroids. It goes 5,000 RPMs. The cannula switching out as much. It's made by Moeller Medical. For me, it doesn't vibrate my hand as much as the 3M device does. So I like it better. I think it's a better device.
There's a question about your access points. So the 4 spots on the buttock you mentioned at the beginning, those are where you deposit the boluses of fat, but you only have 1 or 2 cannula access points?
Yeah, I only have one, usually just that one at the apex, so I can get all the way around. Yeah, I just have one. I think if you put the patient more in jackknife and you go through the gluteal thigh crease, I think it takes you right into the muscle a lot. If you do the one in the cleft at the apex, it's hard to get with the cannulas I have all the way around to the inferior part where the hip dip is. So I like the one that I showed at kind of the midpoint of the apex, and it's far enough away that when you're creating that shelf, the fat's not coming out the hole that you're putting in. So the access point, it's certainly trial and error for each person. I kind of like the single one at the top, but it's the same one you're taking it from the hip in, so you're not making a separate hole.
There's another question here about training. This person is not plastics trained. However, I do tumescent abdominal lipo and BBL with fat grafting. Lives in Louisville, Kentucky, and will I be able to get hands-on training in Sarasota? I do have a Florida license as well.
Do I have a Florida license, or does he have a Florida license?
He has a Florida license.
Well, hands-on training is with models that we make, so there's no human stuff involved. So yes, you do not have to have a Florida license to be trained in Sarasota.
Okay.
There's no live, you're not touching any live patients. That was a good question, though.
All right. Boy, there's quite a few more here. I think we have time for one or two more. Where's the best site to harvest fat?
I think what you want for fat grafting is the most diet resistant fat. And that's the fat in a woman that she has trouble losing. And most women will tell you that around the belly button and in the hips is the most diet resistant fat. So I think it's a heartier fat cell. So I like periumbilical and hip as my primary donor site. So unfortunately, it's a liposuction 360 usually, meaning all the way around. So you start the patient supine, do the belly, flip them over, do the hips and back, and then put everything they think they need into the buttock. You can do a little touch up of the trochanter that may need another hole in the lateral aspect of the gluteal thigh crease. Then you can get to the posterior medial aspect of where the thighs kind of touch. You can get a little bit to the banana roll, and all of that can go into the buttock.
Almost finished. I just wanted to address a couple of questions about the T mode. People are asking whether they can use it during procedures. And we have this for educational purposes only. It's not approved for use during procedures. It hasn't been trained on procedural models. So just for educational purposes at this point. To date, the AI model has just been trained on normal anatomy. So, we can't make claims of how accurate it is for procedures. Okay, we are at the top of the hour. So just to be respectful of everybody's time, I think we will call it a day. Thank you so much, Dr. Salzman. That was a great presentation, great imaging as always. Thank you, Janae, for the fabulous live demo. And thank you so much to all of you for joining us. And just another reminder that you'll be receiving the PDF copy of the slides and a link to the recording of today's webinar. So thank you all again. Enjoy the rest of your day and keep on scanning.
Thanks, Shelley.
Thank you.
Bye-bye.